All right, there we go. I see us on Hoova. I heard the robot voice saying we're recording, so we are live. Good afternoon, everybody. Thank you so much for those who are tuning in. If this is the first session of the day, my name is Alex Sorotsky. First session of the day that you are tuning into. That's what I meant to say. My name is Alex Sorotsky. I use he, him pronouns. I'm a public health educator with the Washington Poison Center. Before I introduce our speaker, it's the same spiel you may have heard before. Reminder that we want you to engage, we want you to ask questions, but you are all muted. There's no way to unmute yourself. So please ask those questions in the chat box, in the Q&A box. One of my jobs is to pay attention to that so that I can field those questions to our speaker when she is ready. Now, without further ado, I am super excited to introduce Dr. Nchinda. Is a general surgery resident at the University of Washington and prior pediatric surgery research fellow at Seattle Children's Hospital. Her research interests include systems-based quality improvement, surgical quality of life metrics, and health policy. She completed her master's in public health in health services and her master's thesis on trends and associated factors in pediatric opioid ingestions in Washington State. She is pursuing a career as a pediatric surgeon, public health researcher, and surgeon advocate. So in all of her free time, she decided to help us out and come speak and share her expertise with all of you here. Part of what is so exciting for me personally in introducing Dr. Nchinda is that she actually worked on some of her capstone project, and ultimately her thesis with the Washington Poison Center. I had the pleasure of being able to sign off on some of those papers. So Dr. Nchinda, thank you. Welcome, and it is wonderful to see you again.
Thank you so much, Alex. It's such a pleasure to be here. Hello, everyone. I am coming to you from Seattle Children's, actually, so this is very fitting as some of the work that I'm going to present is based upon data from here. So again, I'm Nchinda. I'm one of the general surgery residents. Today I'll be presenting work that encompasses my practicum work as well as my thesis work and really trying to shine a light on pediatric opioid ingestion in Washington State. So as a background, the opioid epidemic is not news to anybody. It's something that we see a lot in the media, and it's really an evolving public health crisis that has been going on since the 1990s. It can be classified within three waves. So starting in the late 1990s, we saw the first wave, which is where a lot of practitioners were involved, where we saw overprescription of opioids, then seeing prescription opioids as the main mechanism with which people became subject to opioid misuse and abuse. And over time, we've seen that steady out and more recreational opioid use being the primary agent in opioid abuse and overdose. And so we see that in the late 2000s, 2010, there was a rise in heroin. But then we see that things have really skyrocketed since 2013, where there's been this rise in high potency synthetic opioids that are used, especially fentanyl. And with that, we've seen that the proportion of overdose related deaths really being driven by these high potency synthetics and namely fentanyl. In 2023, 75% of all drug overdose deaths were due to opioid overdose rather than other drugs or other prescription medications. And 92% of opioid cases involve high potency synthetic opioids. Furthermore, 7 in 10 drug overdose deaths in the United States are primarily from illegally manufactured fentanyl. So not fentanyl that we use in a clinical setting, that are used in emergency settings, but those that are generated in factories that are not FDA approved and primarily for recreational use and sale. From 2022 to 2023, we saw that actually the nationwide overdose deaths decreased by almost 4%. And this, I think, is due to a lot of advocacy work that's been done, looking at things like harm reduction and educating people on the adverse effects of opioid use. Now, what's interesting is that this was not the case in Washington State. If anything, there's actually been an increase of about 27% of overdose related deaths within Washington State only. Since our state is different, we hypothesized that this not only affected adults, but also children and adolescents, where there's been so much more focus looking on the adult side, but not as much on how this epidemic has impacted children and adolescents, and also children and adolescents specifically in Washington State. There have been some more recent work that's shown that there was a 3-time increase in opioid-related deaths among U.S. adolescents, and there's a 2-time increase in Washington State only. And that the same way that we see that in adults, that fentanyl is the driver for the opioid crisis, it is also the driver, the primary agent in the pediatric opioid crisis as well. So again, a lot of the motivations from this study came from seeing that there's little scientific attention towards the pediatric population. Some of this was coming from why I wanted to get into this work was coming from my own personal work in, as part of general surgery residency, we see a lot of trauma, and we see there's really the intersection of how trauma is related to mental health concerns and also uh, drug use, and realizing that the pediatric population was a little bit left out of that conversation. And I will say that this is a caveat where we're focusing more so um, on overdose that is related to recreational use, accidental use. So this, again, this is not in the medical context. And so we wanted to look further because there wasn't really any prior research that looked at the impact of the pediatric opioid poisonings in Washington State. And when I first came to the Poison Center, there was already a lot of discussion concerning a couple House bills that came out of our state legislature that were already starting to address opioid-related injuries in children and adolescents. So the aim overall, I would say, for both the practicum and the thesis was to really examine the trends, what factors impact outcomes, what drives opioid ingestion in children and adolescents in Washington State. So looking first at the practicum here, this was a smaller scale. So we basically focused on data from Seattle Children's Hospital. And the inclusion criteria were, of course, pediatric patients, so patients who are less than 18 years of age that had a non-medical ingestion of an opioid, and this was within the years of 2019 to 2024. And these were reported cases. So this will come up a little bit later as far as reporting and whether it's mandatory or not. So these are what we had from the call reports that were told, that were reported to the Washington Poison Center. This is an IRB approved study, and we did a retrospective review based upon looking through call reports and then matching that with the electronic medical records from Seattle Children's Hospital. Looking at the overall distribution, again, this is just from Seattle Children's Hospital. They really fell into 2 big buckets, for ages really very young, like 0 to 3 years old, or adolescent age, about 14 to 17 years old, out of the 50 patients that were in this cohort. We also looked at something called Area Deprivation Index, which I'm not sure if everybody is familiar with. It is a proxy that is used to try and get an idea of the amount of disadvantage in a neighborhood. So it is based upon a map of communities and neighborhoods throughout the United States, and then it's also divided by county. And it factors in multiple things that would be part of, one's socioeconomic status. So things like the general education level in that neighborhood, what hospitals are available, what the average income in that neighborhood is, to try and get an idea of what sort of social limitations and have a more holistic, a more complete picture of someone's socioeconomic status than, say, looking primarily at, just household income. And so the way that it is defined is from the state it's their state deciles from 1 to 10, 1 being less disadvantaged in the community or in the neighborhood, and 10 being more disadvantaged in the community or like a worse socioeconomic status. And then on the national front, it goes from, as a percentile, from 0 to a 100. So we just focus on the state. So given that context, we have here where 1 would be higher SES status, meaning less disadvantaged in the community that the patient is coming from, and whereas 10 would be more disadvantaged or lower SES background. I can clarify that if that doesn't quite make sense. Hopefully that makes sense. Seeing that these are all children that were from Seattle Children's, most of them were in a bracket of the ADI where they were coming from higher SES backgrounds. So communities that did not have a significant amount of social disadvantage. But yet, we still saw that fentanyl was the most consumed opioid. So this graph shows all of the substances that were reported to have been consumed by the child. Polysubstance meaning that there was an opioid and then an additional medication, say a beta blocker or a water pill or something like that, that uh, uh, accompanied the ingestion of the opioid. But by far and away, we see that fentanyl is most prevalent, followed by oxycodone, and then by Suboxone, which both of these are subscription. Suboxone and oxycodone are prescribed medications. And then when we looked at the placement of these children afterwards, most of them ended up returning home. There were a couple cases where the child died due to the severity of their injury. There was one adolescent that ended up going to um, inpatient rehab for mental health therapy. And then there were about 11, or there were 11 children that went to CPS and to the care of their relative, as far as being placed in a different area based upon their home being determined as unsafe, based upon this accidental ingestion. When we looked overall, I would say as a summary of this data that was across between Seattle Children's and what was reported to the Washington Poison Center, we saw that most of the ingestions, the accidental opioid ingestions, were in children less than 10 years of age. It was accidental, so we'll talk a little bit about that, of the two different populations. But most of them being younger children, it was accidental of them getting into medications that they should not have had a hold of, and really gets to certain medications not being properly secured. We wanted to expand, or I wanted to expand on this further in looking at, looking at the state as a whole, and in this way being able to compare between different counties. As you saw with some of the data, in that we are only having Seattle Children's, I think that that definitely filtered our population and didn't really capture the diversity across the state as far as resources and socioeconomic landscape. And so from the thesis level, this was expanded. Again, was again a retrospective study working with the Washington Poison Center. Here we only relied on the report registry. It was similar again, where these were all children under the age of 18. The time period was a little bit longer, so 9-year period from 2014 to 2023. And the reason for choosing those years was really to capture this last third wave of the opioid epidemic. As we saw, really 2013 is where fentanyl really took off as a primary agent. And so we wanted to see what the landscape looked like in this current time, in this current wave that we're in. We looked at demographic factors. Again, area deprivation index was a factor that we looked at. We also looked at accountable communities of health. This is another way to classify areas of the state that is based upon Medicare groups. And so these are basically different based upon Medicare and resources in the region. And It's a way to classify how resources are distributed based upon the multidisciplinary care that is provided to those who receive Medicare and Medicaid in that region of the state. We looked at ingestion details. We also looked at medical outcome. And so our big focus was looking at severe or major outcome. This was defined as like a life-threatening event that occurred due to the opioid ingestion. And then our analysis, we're really looking at trends and associations and statistical factors that would be able to assess for any significant associations between any of the factors that we looked at, such as demographics, and the final outcome being either fentanyl ingestion or a severe medical outcome. This is a map of our state of Washington that has 39 different counties. We are you can see where we are. This is Seattle here, and we have King, and Pierce is right next to us. And we can see that, we have a very diverse, really spread out state. I know that there's a lot of concentration within King County, but what was nice was that we got a good representation of 38 out of the 39 counties within this study. We had a total of 2,878 reported pediatric opioid ingestions that were unique ingestions. I will say we filtered out cases where there were duplicates, and the mean patient age was about 7.5 years old, plus or minus 6.5 years. Again, on the right, we see those like two buckets really, where most of these pediatric opioid ingestions were in young children, 0 to 3 years. And then the next biggest group, or the most represented group, was the late adolescents. And then here within this larger subset, we see more of the pre-adolescents being represented as well. The largest number of cases came from King and Pierce counties, where we had 24% of cases coming from 24% of cases and 17% of cases, respectively, coming from those counties. These are those ACH regions. So you can kind of see here, and remembering the prior map, is healthier here is essentially King County, and elevated health is essentially kind of Pierce County. But these are ways that you can group up multiple counties in the state based upon resources that they're obtaining from Medicaid. Again, we see that most of these cases were coming from both the regions where we are, kind of King County area and Pierce area as well. This graph is trying to put quite a few things together, and so I'll try to orient. So I would say a big takeaway is really the lines that are most important. So the black line here that has the rectangles, that's fentanyl. And this dashed line here with the smaller dashes is oxycodone. And then the larger dashes are hydrocodone. And your axes that you see here on the bottom go from 2014 to 2013 on the x-axis. And then you have opioid ingestion count coming on the right axis. And it's simply showing what we predicted, but graphically, that the amount of cases for fentanyl have just really skyrocketed in the past 9 years. Whereas, if anything, the cases for prescribed oxycodone and hydrocodone plateaued and then have declined over the years. What the bars are showing are basically the ADI, the area deprivation index. Again, the lower decile meaning there's, that higher SES background, less disadvantage. And then the higher decile, higher ADI score, meaning more disadvantage. And the decile 7, 8 are consistently the highest, have the highest count in cases. So really showing the aim of this is really to show that the fentanyl cases amongst children has really skyrocketed over the past 9 years. And most of the cases that we're seeing are in counties that have more disadvantage and have a higher deprivation index. There are a total of 205 reported cases of pediatric fentanyl ingestions. So these are not just opioid ingestions, but looking specifically at fentanyl. There were 205 cases. And we see that there are really two groups where this occurred is in the 0 to 3 group and then in the 14 to 17 group, compared to less cases in the pre-adolescent group. We next wanted to do more of a standard regression model to look at significance. So on this table, these factors were assessed to see if they were associated with a higher odds of there being a fentanyl ingestion. So here we see that being of an older age, and then also being from of a female gender was had a higher increase the odds of the pediatric patient, ingesting fentanyl, or that it was associated with fentanyl ingestion. When we looked furthermore at looking at state decile, what we saw earlier was that the trend that we saw in there being more cases in areas of the county that had more deprivation, that was a significant association. And so that existed, and we can see that here, that state decile was a strong associated factor, and that particularly being of a higher decile or a more disadvantaged background was strongly associated with fentanyl ingestion. What was also interesting was looking at what the reasons for ingestion are. So we have these two different age groups, and they're very different developmentally. And so what leads them to ingestion is also going to be very different. Most of the cases overall were unintentional. And so that's this on the left, on this pie chart, really 68% of the cases were unintentional ingestions. But then we see that the next most prevalent reason was intentional, as far as being related to a suicide attempt. And what's interesting when we break that down by age group is that amongst the 0 to 3-year-olds, they're essentially all unintentional. Kids playing around, mistakenly ingesting a pill that was exposed to them. Whereas in the 14 to 17 group, the more prevalent reason for ingestion, was really intentional, and one would say related to either suicidal ideations, attempt, and getting to there being perhaps a mental health underbelly to what is driving the pediatric opioid ingestions within the adolescent population. We next wanted to then see what factors were strongly associated with a life-threatening outcome. And so when we looked through, we saw, looking at the rightmost odds ratios, that an older age, was significantly associated with an adverse outcome. And within the adolescent group, being in a higher ADI decile, so being from a more disadvantaged community, also had a higher odds of there being a life-threatening outcome. And then, of course, fentanyl compared to other opioids that were ingested, fentanyl had a 4 times greater odds of resulting in a life-threatening outcome for the child or adolescent. Looking through all of this data, I think key takeaways and things that we can discuss here are, what are the risk factors for each age group? And when we identify that, how do we then take action? Like how does that then inform the sort of advocacy that we do and the sort of harm reduction that we do? Takeaways that I learned from this was, that the reasonings and the path were really different for the two main groups that we saw. For young children, both numerically and also anecdotally, reading through each of the call reports, was primarily due to safe storage. It was medications not being locked in a cabinet. It was purses that were left open. And so that then brings up education. And there's been some literature, I would say that's probably the bulk of the literature that's around as far as awareness and education is teaching safe storage practices. And and with safe storage practices, also safe disposal practices as well, making sure that when people are not using when they're done with their prescription medications, or if they do have recreational drugs in the home, being very cognizant about making sure that space is safe for young children. On the adolescent side, one would say with these pediatric opioid ingestions, it's a little bit different that it's not quite accidental for adolescents and really getting to why. What are it seems as though that opioids are used as a coping mechanism, and one can think through how they're exposed to that, but then also what things are driving that, and is there an unmet need as far as behavioral and mental health? What was also key takeaway for me, and it's sadly it correlates with other adverse things that we've seen is there being a greater burden in communities that are socioeconomically disadvantaged. And it's interesting because we look at the opioid epidemic and see that it impacts every socioeconomic class. It impacts every racial group. However, I think it is important to think about where there are disproportionate effects. And within our state, at least, it looks to be that areas that do have less, where families are more socioeconomically disadvantaged, they are facing a greater burden of fentanyl ingestion, and then also there being life-threatening effects from that ingestion. This was an article that was published in the New England Journal of Medicine, and it was looking at specifically data from Oregon. And so the Oregon Poison Center and the Oregon Health and Science University collaborated, and they were similarly looking at trends in their state. And kind of a summary of the data was that they saw that they looked at children younger than 6 years old and saw that in 2013 they had no reported cases of pediatric opioid ingestions. They had 2 cases in 2021, but by 2023 they had 16 cases of illicit fentanyl ingestion. We have a total essentially in that same time period, we have a total of 203. The prevalence is overall much higher in Washington state. As to why that is, I think that would be a question for another study. But I think it does raise that this is not only an important issue in Washington state, or in Oregon, but also, Washington has a similar problem, and that there is a need to have focus on it as well here within our state. And thinking about how do we decrease the incidence of pediatric opioid ingestions, there have been some recent legislative efforts. So there's House Bill 6109 that came out not a year ago that looks at child safety. So looking at whether homes are safe for children to return to. And this was something that we touched on with my practicum, and having Child Protective Services assess, is this an accidental incidence where we can educate parents, or is the home really unsafe? And being more critical in how we make those assessments. There's also been what followed that then was House Bill 1956, looking at education and safe storage education. And what is important with this bill is that it not only focuses on education for adults, but also for children. I think we're getting to a place where, especially for adolescents, that we need to be, talking through what to look for. Perhaps, and this is a discussion that we can have of, should we be distributing naloxone in schools at this point, and not just, not only handing it to parents to have available. And so this House bill was a big effort in moving that discussion and those efforts forward. And this gets to harm reduction and naloxone. There's also another initiative within the state, start one that mails like envelopes to families to be able to just easily dispose of prescription medications that they have in their homes. I think there are different ideas that we can discuss as to how do we make resources available in certain communities, and especially when we look at there being disproportionately more burden in certain communities, whether there needs to be more resources that are invested in distribution of things like naloxone in certain schools and in certain communities. There are limitations to the work here. It's all retrospective. One thing that I've discussed with quite a few people is the reporting. This is the data that we had from the Washington Poison Center, and our state doesn't have mandatory reporting. There's an ethics discussion we can have as far as mandatory reporting, but what we're capturing is what was recorded. So there is a possibility that cases that were really, really severe, where there was mortality, we're just not capturing. We had a discussion with this when presenting at our prior NPH symposium, meeting someone, a community health worker, where they do morbidity mortality analysis, and recognizing that she was aware of a couple mortality cases that were not within the data set that I had. And so that's a larger discussion on how to perhaps collaborate or encourage certain centers, or have a more centralized um, method or referral system to make sure that we really are capturing everything in all the cases in our state, both those that are very, very severe and those that are perhaps minor that maybe don't make it to an emergency room. Another caveat that came up during the thesis presentations was race, there not being any race or ethnicity data in the Washington Poison Center data. This is something that is consistent for all poison centers, and looking at the few bits of literature that are out there, and looking at the National Poison Center database. That's a discussion as to how strongly we believe race and ethnicity to be a predictive factor. There is some confounding there as far as how much that plays into socioeconomic factors of like education level and income, and perhaps a case can be made that ADI is a more comprehensive measure of socioeconomic status, devoid of race. As far as next steps, I would say from this, I think there is still more work to be done from a legislative capacity, with these House bills, is making sure that there is funding and behind them, that we, as a state, have said we do care about awareness, we do care about child safety, but what does that mean as far as on the ground level? And I think that's another study that would be done as far as uh, within communities, are they actually receiving resources to be able to adequately instruct and inform both parents and children about opioid ingestions, and specifically about fentanyl. Next, really optimizing reporting. So I think this is where there can be more collaborative efforts. I think through the Washington Poison Center, or through other methods, whether there should be a more centralized reporting referral system with different hospitals. That's something that we ran into, in that, the initial practicum was done through Seattle Children's because that's where I had access to medical records, but perhaps for these cases, there should be a way that that data can be extrapolated more easily from hospitals throughout the state. And then next, expanding access to harm reduction resources. So again, thinking about how do we make it easier for families to have methods to store medications easily? How do we make it easier for families to be able to dispose of opioids that don't need to be in their home? How do we make it easier for people to be able to step in and mitigate adverse outcomes from overdose. So maybe that's giving something like naloxone that can really, in a timely manner, be able to reduce the cardiovascular and the pulmonary and the neurovascular effects of overdose. So overall, we see that pediatric opioid ingestion is an increasing problem in our state. It remains understudied. Washington state particularly has a disproportionate increase. There's a disproportionate burden within our state for both adults and pediatrics and the pediatric population. And fentanyl ingestion and the life-threatening effects are strongly associated with adolescent age and very much associated with being from a socioeconomically disadvantaged community. And we need further research, further collaborative efforts to understand the scope of the problem, but also to inform effective preventative practices. There are many people to thank in this work. I would say key people from the Washington Poison Center, Alex, that you've already met. He was the one that was managing my practicum and making sure that I was able to get things moving forward. And both him and Jimmy were so instrumental in getting this data and being so encouraging in this work. From the UW School of Public Health side, my thesis chair is Dr. Paul Fishman, who really helped with a lot of this data and making sense of what sort of message that we want to put out there, and Molly Firth as well, and in helping think through what the advocacy, what the policy lens of this work is. And lastly, but not least, Suzanne Mazer, who is our collaborator. She's a medical toxicologist and ED doc at Seattle Children's and was very instrumental in getting the Seattle Children's data for the practicum, and that's spearheading the rest of this work. This is my email address, and I'm happy to take any questions. Thank you so much all for your time.
All right. What an excellent presentation. Thank you so much, Dr. Nchinda. Um, I want to apologize too. I realized when I introduced you that I said capstone project. It was your practicum project with the Poison Center. So thank you again for that. I'm chuckling too, folks, because as Dr. Nchinda said, like myself and Dr. Leonard and Dr. Mazer kind of helped out along at various points. And there was this early on meeting where we were all trying to figure out what we need for IRB and how do we sign it under
Yeah.
and all that. And I
Yeah.
am this public health dude in this land of doctors using jargon that I could not follow. It was fascinating though. So it was such a pleasure to see your work from beginning to end here. All right, I'm going to refresh Hoover here and see if any questions are coming in. I am seeing a question in the chat box here. Are we able to share the PowerPoint? We will post the recordings up, and then we can get the slides embedded into Hoover as well. We'll probably have them as a PDF, but format doesn't matter. You'll still be able to see the slides. Um, Let me see here. You know what? This is another just comment. As someone working in the Washington Poison Center, I really loved that you added in the safe storage messaging. I think safe storage applies to so many things.
Mhm.
Substances, cleaners, like so many things. If we can store it safely, we really do reduce harm, and reduce access to that. I've also found myself kind of reflecting on you made the comments on like one of the limitations with Poison Center data is like a lack of race and ethnicity data. And on one hand, it would absolutely like give us more data points to consider. And for context, for those who are less familiar with the Poison Helpline and with Poison Center calls, one of the big reasons we don't ask race and ethnicity data is we don't want to spook callers. We don't want to alarm them, and a lot of folks, very understandably, get a bit concerned when we start asking too many demographic questions. And if this is helpful for folks to keep in mind, if you ever do call the Poison Helpline, 800-222-1222. You can be anonymous. You don't have to give us your name, and all of that. But yeah, just a little context on that. Yeah, and I'm also thinking too, like you made the comment, made the point that part of why with your practicum we went with Seattle Children's is we had that access already. And even with that access, and even with both groups being on board, it took time to like get
Mhm.
all
Yeah.
the various like layers of
Oh,
approval going. And so that's part of what one of the difficulties with this kind of work is just how much time it takes for I love the head nods. Yeah.
yeah.
How much time all this takes just to get approval to go, let alone all the deep analysis you did.
Yes. Yeah, it's I think that definitely is probably a barrier. That is a barrier in this work, in being able to accurately capture what's going on. And it doesn't mean that we can't analyze what we have and just recognize that it's not going to be perfect, that there is going to be a portion of underreporting. I think we still were able to show what we suspected. And I think being able to have this data is helpful to take to, say, a legislative board, to, say, a hospital, and to be able to first declare like, hey, there is a need, and hopefully that can help spearhead other ways that we can brainstorm how to make the bureaucracy portion, the approvals portion, more streamlined.
Yeah, yeah, and it's always that tricky balance because of course we want to protect patient info
Yep.
and all of that
Yes.
and yeah. All right, folks, let me refresh Huva again. While you're thinking of questions to ask, for you, Dr. Chinda, with all the spare time you have, if you were going to continue this kind of research using the data sets you've already done, what new directions might you be interested in taking this?
Yeah, I am interested in seeing what the effect of harm reduction is on the ultimate outcome. So I say that because there were a few cases in reading through just like the narrative on the call reports where parents administered naloxone right away. And even though the amount that their child had consumed was significant for the size of their child, they had very minimal effects.
Mm,
Didn't need to be in the ICU, didn't need to be on any sort of didn't need to have any sort of intervention. And so I think it would be interesting to be able to look at some of this data and tease out how much, for the cases that had a pretty minor effect, how much of those cases or how many of those cases were associated with use of naloxone. Perhaps that could also help inform um, the importance of its distribution and to see whether it's actually being utilized or not. So I think that would be really interesting. I think another component for this study is, it was primarily quantitative. I think there's also a qualitative aspect. I would love to, be able to do like interviewing for healthcare workers, community, um, community health specialists and workers on their end, what the healthcare delivery side looks like on their end, to better inform, what their patients are going through, what cases look like, what they believe to be effective as far as education. I may say I think safe storage is really important. We need to have these resources, and they may say, actually, this is where the problem lies. Actually, for this setting of performing education in this certain setting actually isn't effective, even though education, generally one would say is helpful. So I think having that qualitative side would be then another step that I'd want to take in this work.
I love that answer. Thank you. I think it's so easy to assume, well, this is obviously the barrier, and then make a bunch of interventions without actually asking folks, hey, what's the barrier for you?
Yeah.
So I appreciate you saying that. All right, I'm going to do one final refresh on Hoover. While I'm doing that, I will ask you my final question. If attendees were to take away one thing, one single thing from this, whether that's an action item, a knowledge point, an attitude shift, what would you hope that would be?
I would say the big takeaway would be recognizing that children are experiencing a lot of the same adverse things that adults are. And so to not forget that this opioid epidemic is really affecting everyone, including children. And my takeaway would be really thinking through how best we can advocate for children in this setting. And that can be small ways. So maybe that is in someone that you know and being able to educate, or in a school setting where this might be something that is you could raise in like a PTA meeting, or even for those who feel compelled and have their own professional experiences, thinking about how that can be put in a letter form, whether to their state congressman, or in an op-ed. But I would hope that people would take away that mainly that this epidemic also affects children, and that our state has a higher burden than others.
Well, thank you. Thank you for adding that. I think it's so easy to take research, to take data and keep it as research and data rather than like apply it and do something with it. So I love how you frame that of asking folks to take it a step further. Um, thank you. I'm getting some thank yous pop up in the chat box. So thank you for all the work you're doing, Dr. Chinda. Folks, if you think of any questions after we go ahead and end this session, feel free to add it in that chat box. Still, that will still remain on Whova. I encourage you to check out the various community boards as well, and we can keep some ongoing discussions going. All right, so we will go ahead and wrap this up. Our final session of the day will be at 3:45, so you can enjoy a little bit of a break, maybe get a cup of tea, take a little stretch. And Dr. Chinda, thank you so much for your time.
Thank you so much. Thanks for having
Yeah,
me.
thank
Take
you
care,
all.
everyone.
Yeah,
Bye.
bye-bye.